What's critical to this, though, is to have data. The doctors in the hospitals have to have data on how often these problems are occurring and how much they're costing, and generally they don't have that data. And you have to have data on how often those problems are occurring and how much they're costing, and generally you don't have that data, at least not formatted in the right way. And you both have to have the same data, and you both have to trust each other. Because if you have your own data, then you're going to sit around the table arguing over the pie charts, not actually coming to a better deal on outcomes. Now, warranty is not the same price for everybody, so you'd say, some patients are riskier, the warranty price would be higher, but in every case, you would still have the incentive to be able to get those complications, readmissions, infections down. Now, here's where it gets really tricky. And lots of people are talking now about warranties and bundles, and you're talking about bundles and warranties per procedure. Where it gets really tricky, though, is what if you don't do the procedure at all? So let me take a hypothetical example. So I've got a hypothetical physician here who sees 300 patients a year who come in for some problem that they have. Doctor gets paid $100 to see the patient, new patient, they spend more time with them, evaluate them. They decide that 2/3 of the patients are going to get the procedure. Doctor gets paid $600 for those procedures. Procedures done in the hospital gets paid $7,000 for the procedures. So the payer, the purchaser, whomever, is spending $1.5 million on those 300 patients. If you want to know what I'm thinking about, think stents, but could be anything. Key thing is, up to 10% of those procedures may be avoidable with patient choice or some other approach. Now notice, I'm not saying that the procedures were inappropriate. The procedures were appropriate, they weren't wrong to do, but the patient might decide that they didn't want to take the risk associated with that, or maybe they want to try medication management and see if that would work as well to reduce their chest pain or their knee pain or whatever, okay? Now, if this physician or hospital would even admit that they think that 10% of those procedures could be avoidable, what would happen? Health plan will rush in with a utilization review, a prior authorization program to try to make sure that we're not doing 10% unnecessary procedures, which would be a really good deal for you. If it actually happened, you'd spend 10% less, but not a terribly good deal for the doctor or the hospital because they get paid per procedure. So they'd lose money. So is there a better way? Well, first of all, notice something. Most of the money is not going to the doctor. Less than 10% of the money is going to the doctor. So let's talk to the doctor and say, what could you do to help us here? So what if you said to the physician, I'll pay you more to spend that time with the patient on those to try to decide whether they want the procedure or not, rather than having to rush them out the door so that you can get back to the cath lab to do more stents. So we pay them more, better for the patient. They do 10% fewer procedures. They might actually be able to get more money as a result of that and still save you money. So doctor could make more, you could spend less, patient's better off because they're not getting unnecessary surgeries. So where's the money come from? Well, the money comes from the hospital, right? So does the hospital have to lose in order for the physician to win and for you to win? Well, the issue is what should matter to the hospital is their margins, not their revenues. And the way we pay today for health care, the only way they get higher margins, earlier example, is that they have to get more revenues. So what if we could fix that? So what if I actually said, so same numbers I just showed you, what if I said, let's look at the hospital's costs. So here's that $7,000 that the hospital is getting paid. I'm going to assume that half of that is fixed cost. Doesn't change depending on how many patients the hospital has. I'm going to assume 45% is variable. It's the cost of the stent, it's the cost of the other kind of disposables. And I'm going to assume that the hospital is getting a 5% margin on these procedures. Okay? Now, what would happen? I bet those of you all the way in the back wish you were sitting more up front, aren't you? Wouldn't you? What would happen if you actually ended up doing 10% fewer procedures? Well, let's think through the economics of this. So the hospital's fixed costs are fixed. So therefore, the hospital still needs to get the $700,000 in fixed costs they were getting before. The hospital's variable costs are variable. So if you have 10% fewer procedures, you have 10% less variable costs. If the doctor is getting 2% more money, let's give the hospital 2% more money on their margin than they were getting before. Now, what's that all add up to? Well, it adds up to 4% less money than the hospital was getting before in revenue. But should the hospital care? Hospital's covering its fixed costs, it's covering its variable costs, and it's getting more margin than it was getting before with 4% less revenue. Not 10% less revenue, but 4% less revenue, because I looked at what the hospital's actual costs were. Now, what's it all add up for to you? Well, drum roll, it's actually 4% less spending than it was before also. So we actually end up with a win-win-win. Doctor's making more money, hospital's making more money where it counts, and you are spending less. And the patient's better off because they're not getting a procedure that they really didn't end up needing in the first place that could have caused them other kinds of problems and kept them out of work when they didn't really need to be out of work. Now, what payment model supports that? Well, you don't want to go back and start sitting and renegotiating all the fees, right? Because what's your guarantee that they're actually going to be doing fewer procedures? And you can imagine the discussion when the hospital comes and says that pay me more per procedure now, and trust me, I'll do fewer of them. What you really want to do is to say, what I've got is 300 patients who have a health problem. I am spending now a little over $5,100 per patient to have that problem dealt with. So the hospital and the doctor should come to you and say, you know what, we can do that for 4% less. Now give us that money for those patients and let us figure out how to redesign care. So they can decide how much the doctor needs and how much the hospital needs, and they can decide whether they're going to pay for more for office visits or procedures or whatever. Let them decide, not have you trying to negotiate over 7,000 CPT codes. This kind of condition-based payment actually puts them in charge of controlling costs, not you. And instead of spending all this time and money having health plans, put all these programs in place to watch over them and to watch everything that they do and try to control everything from somewhere else, put them in charge of controlling their own costs, which is what every one of you does in your own business every day. Now, once they actually have that control, they can start thinking about how to do things differently the way Geisinger did. So for example, the doctor might say, you know what, I think we could actually do those procedures at less expense. Maybe I don't need to use all those drug-eluting stents, and maybe I could actually get the vendors to give us a discount on those stents. And if you did that, the doctor could make more money, the hospital could make even more money, and you could get a lower price because now all of a sudden they are in charge of figuring out how to reduce costs. And they can think about how to compete with other providers based on being able to do that. Today, they don't do that. Today, you make them compete on volume, do more procedures. What you want them to do is to compete on how efficiently they can do the ones that they're doing and do even fewer of them. Now, the opportunities and the solutions vary by specialty. In cardiology, it's using less expensive and invasive procedures. In orthopedic surgery, it's reducing infections and complications, less expensive surgery. In psychiatry, it's helping keep the patients with behavioral health issues out of the emergency room and out of the hospital. In maternity care, it's reducing elective C-sections and reducing the early deliveries and the use of the NICU. All those are opportunities. The barriers in the payment system are somewhat different, but they all are driven by the fee-for-service structure. And the payment models may be a little bit different in each case. But wouldn't it be better to be paying people on that basis where they can actually control costs and outcomes in the way we're paying them today? Now, these are not my ideas. These are actually ideas from physicians. And the major national specialty societies are actually working on this. In fact, you have here in Wisconsin, the local chapter of the American College of Cardiology wants to implement a program just like I talked about here. What's the problem? They can't get anybody to pay them that way. Not just them. Neurology, gastroenterology, oncology, radiology all want to be paid differently because they are sick of the fee-for-service system too, and what it makes them do and the fact that they can't give good care to their patients. But they need somebody to pay them differently to be able to get there. What's the biggest barrier? Health plans don't want to change. Health plans don't want to change the way they pay physicians. And it's not good enough to get one payer to change. Because what's the physician supposed to do? Okay, I'll keep you from getting an infection. I'll give all the rest of you an infection. Doctors don't work that way. Hospitals don't work that way. So they've got to be paid by everybody. Now, I'm not worried that all health plans aren't going to do something to change payment because there's such pressure around it. What I'm worried about is they're all going to change payment differently. And the physicians and hospitals are going to have 17 different payment systems because all the health plans are going to come to you and say, guess what? I have an even better payment system than Humana does. No, 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 United has the best system. No, Aetna has the best system. Right? What we want to be doing is competing about outcomes, not about who has the best payment system.